Welcome, USMLEers! My name is Zuk Azalishvili and I'm the founder of USMLE. USMLE is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your STEP exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at USMLE. Now, let's start rolling. Today we continue the respiratory system, and now we will move on to respiratory physiology. Respiratory physiology will hopefully be covered in 2 episodes, and today we will discuss 7 very important topics in our episode. And let's start by discussing the lung volumes and capacities. The lung volumes and capacities are the different amounts of air that are differentiated from each other based on the expiration and inspiration, and we will talk about them in detail. But before we get into details, let's first draw a contrast line between the lung volume and the lung capacity. Do you remember what the difference is between these 2 terms? Yes, I agree. I hope that you're telling me that lung volume is just one volume. However, the lung capacity is the sum of at least 2 physiologic lung volumes. And the first and probably the most important, or let's say the easily understandable volume, is the tidal volume. Tidal volume is the amount of air that moves in and out of the lungs with quiet respiration, with quiet inspiration and quiet expiration. In other words, when we breathe in a way that we don't think about our breathing, we are inhaling the tidal volume and we are also exhaling the tidal volume. And the tidal volume is usually around 500 milliliters. However, tidal volume can be changed due to physiologic conditions. For example, if the patient has SOB or even pathologic conditions like COPD or let's say pulmonary fibrosis, can change the tidal volume. And more on that in the pulmonary pathology section. However, let's continue talking about the pulmonary volumes. The second volume that I would like to discuss with you today is inspiratory reserve volume, in short IRV. IRV is the amount of air that we can inhale after normal inspiration. What that means is that when we take in a breath, our lungs get full with the tidal volume. However, on top of that, we can still inhale an additional amount of air. And that additional amount of air that we can inhale on top of the inhaled tidal volume is inspiratory reserve volume. And inspiratory reserve volume can be anywhere from 3 to 4 liters. The next volume is the expiratory reserve volume. And by this time, I hope you have at least an intuitive understanding of what the expiratory reserve volume is after discussing the inspiratory reserve volume. Expiratory reserve volume, or otherwise called ERV, is the amount of air that we can still breathe out after a normal exhalation. Let's put this in other words. For example, when I exhale quietly and peacefully, well, I exhale my tidal volume, right? But then there is an additional amount of air that I can exhale additionally on top of already exhaled tidal volume. And that amount of air is the one that's called expiratory reserve volume. And expiratory reserve volume is usually 1 liters or 1.5 liters. And the last volume, which I would like to talk to you about, is the residual volume. The residual volume is the amount of air that stays in the lungs after maximal expiration. In other words, when we exhale all the air that we have inhaled, the lungs do not collapse. So there's still some remnant air in the lungs that we can never, ever, ever exhale. And that's called residual volume. And a very, very high yield clinical point about the residual volume is that since we do not exhale residual volume, or RV, spirometry cannot detect residual volume or any lung capacity which contains residual volume. For example, this is functional residual capacity, total lung capacity, that we'll discuss in a second. But the idea is that spirometry measures only that amount of air that we can literally exhale, but residual volume cannot be exhaled. And there are some other methods of measuring the residual volume if we want to measure it, right? And they are very complex and complicated. We can use the helium and the special devices. However, they are not commonly tested on step 1. And plus, when we have the pathological conditions of the lungs which change the residual volume, for example, we have the obstructive or restrictive lung diseases, we can infer what will happen to the residual volume. We don't necessarily have to check it or calculate it. This is what I'm trying to say. Okay, now let's move on to the capacities, and let's remind ourselves that the capacity is the sum of at least 2 different lung volumes. And the first capacity that we will discuss here is inspiratory capacity. Inspiratory capacity is the total amount of air that we can breathe in after a normal expiration. In other words, when I exhale, then the amount of air, the maximal amount of air that I can breathe in, will be called inspiratory capacity. Okay, now let me give you a question. Can you please tell me which lung volumes are included in the inspiratory capacity? Are you saying that it's inspiratory reserve volume and the tidal volume? If yes, you are unbelievably cool, and that's right, I agree. Because the air that we can inhale after a peaceful, quiet exhalation is the sum of the tidal volume and the inspiratory reserve volume. Okay, now another capacity is functional residual capacity, or FRC. FRC is the amount of air that stays in the lungs after a normal, quiet exhalation. In other words, when we exhale our tidal volume, then the amount of air that stays within our lungs is called FRC. And I would like to ask you the same question that I asked you about the inspiratory capacity. Can you please tell me which lung volumes are included in the functional residual capacity? I hope you're saying that it's expiratory reserve volume and the residual volume. These 2 volumes together create the functional residual capacity. And functional residual capacity is a very, very important physiologic point in the lung mechanics, which we'll talk later in today's episode. But let me say it in short that when we are at our FRC, the inward pull of the lungs and the external push of the chest wall are balanced. And this will be a very, very high yield point later on. Now, let's talk about the vital capacity. Vital capacity is the maximal amount of air that we can exhale after a maximal inspiration. In other words, we should inhale air as much as we can, and then we should exhale the air as much as we can. And can you guess which volumes are included in the vital capacity? I agree. This is inspiratory reserve volume, tidal volume, and the expiratory reserve volume, because these three volumes are those amounts of air that we can literally exhale if you want to exhale maximally. Now, you may have heard the term forced vital capacity, and I have been asked many times what the difference is between forced vital capacity and the vital capacity. And let me answer this question right now, right here. In terms of the volume, there's no difference between VC and the FVC. Both of them signify the amount of air that we can exhale after maximal inhalation. However, the difference between them is about the speed of exhalation. In forced vital capacity, we force our lungs to exhale that amount of air in a short period of time. However, vital capacity is when we just quietly exhale all of the air that we can possibly breathe out. And I would like to say that forced vital capacity is probably more important when talking about the pathological conditions, specifically the restrictive and obstructive lung diseases. And overall, the clinical significance of these lung volumes and the capacities that we're discussing right now is in the differentiation of obstructive versus restrictive lung diseases, which we'll cover in detail in the respiratory pathology sections. And the final capacity that we'll discuss is TLC, or total lung capacity. Total lung capacity is the total amount of air that is present in the lungs after a maximal inspiration. In other words, TLC, or total lung capacity, involves all the lung volumes together. This is inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. We can also say that TLC is the sum of the vital capacity and the residual volume, because the vital capacity itself was the sum of inspiratory reserve volume, tidal volume, and the expiratory reserve volume. Please keep in mind that TLC is not the same thing as vital capacity. Vital capacity is the amount of air that we can exhale after maximal inspiration. Meaning vital capacity never includes the residual volume. In contrast, TLC always includes the residual volume. And this was the discussion of the lung volumes and capacities. The next topic that we'll discuss in the first part of the respiratory physiology is the physiologic dead space and its calculation. Before we move on to the actual formula and its utility, let's discuss what the physiologic dead space is and how it is different from the anatomic dead space or the alveolar dead space. Physiologic dead space is actually the sum of anatomic and the alveolar dead space. Okay, now can you please remind me which air comprises the anatomic dead space? If you are saying that anatomic dead space is the air that stays in the conducting respiratory zone, you are absolutely correct. So it's the air that stays in the nose, nasopharynx, oropharynx, trachea, and the bronchi, right? And also the bronchioles and terminal bronchioles if we want to be super specific. Okay, but then what is the alveolar dead space? Alveolar dead space is the amount of air present in the alveoli that does not participate in gas exchange. Generally, the word dead space means the air that does not participate in gas exchange. And then when we specify whether it's anatomic or the alveolar dead space, we simply signify which part of the lung we are talking about. Are we talking about the conducting zone and its dead space? That's called the anatomic dead space. But if we are talking about those alveoli which do not participate in gas exchange, at least partially, then we are talking about the alveolar dead space. Okay, now here's my another question. Which part of the lungs do you think gives most of the alveolar dead space? Is it the apex of the lungs or is it the base of the lungs? I hope you're telling me that it's the apex of the lungs. And let's discuss the physiology behind this concept. The apex of the lungs are the top parts of the lungs. And when the right heart, pumps blood towards the lungs, the blood moves against the gravity, right? Because the blood moves upwards. Therefore, perfusion is smallest in the apices of the lungs. As for the air, well, inhaled air in the apices of the lungs are also small in amount compared to the amount of air inhaled in the bases of the lungs. However, since air is very light in terms of the weight compared to the blood, then this difference between the amount of air going in the apices and the bases of the lungs is not that significant. In other words, in the apex of both lungs, alveoli are filled with significantly high amount of air, but the perfusion through the pulmonary capillaries is very small. Therefore, there is some amount of air in the alveoli of the apices which do not participate in gas exchange at all because simply there is not enough blood going to the apices to get the oxygen from this air of the apical alveoli. And this also brings us to a very, very high yield point for USMLE step 1. This physiology that we explained right now is the exact same reason why Mycobacterium tuberculosis loves to reactivate in the upper lobes. As you remember, Mycobacterium tuberculosis, or TB in short, is aerobic bacterium. And if it's aerobic, it means that it needs a lot of oxygen. So it needs those alveoli which maintain considerably high amount of oxygen, and these are those alveoli which contain the dead space, so apical alveoli. Right, now we said that physiologic dead space is the sum of anatomic and the alveolar dead spaces. What is the formula for physiologic dead space? First of all, physiologic dead space is marked by V subscript D, or VD, and let me tell you the formula. VD equals to VT, which is tidal volume, multiplied by arterial CO2 minus expired CO2 divided by the arterial CO2. Here's the thing. I have seen some people memorizing this formula to calculate the physiologic dead space on the step 1. And memorizing the formula definitely helps us get such kind of questions right. However, I think it's more important that we understand the idea or the logic behind this formula rather than memorizing it without the sense. And plus, if we understand the logic behind, then we will retain this information much longer and we will be more likely to recall this formula on the day of our exam. Why do we have such kind of formula for the physiologic dead space? Let me tell you this. Where is the CO2 more diluted, in the pulmonary arteries or in the exhaled air? I hope you're telling me that CO2 is more diluted in the exhaled air. And the reason for this is that when we exhale the air, we exhale not only the air that received CO2 from the pulmonary capillaries, but also the dead space, meaning the air that stayed in the conducting zones and also the alveolar dead space. And if we recall from physiology, the dead space air contains almost zero CO2. So when these two airs, meaning exchanged air and the dead space, mix with each other, the concentration of the CO2 in the exhaled air decreases compared to the concentration of CO2 in the pulmonary arteries. And then we divide the change in the CO2 concentration by CO2 concentration in the pulmonary arteries, because this drop in carbon dioxide concentration in the exhaled air is directly proportional to the physiologic dead space. In other words, the more air we have that does not participate in gas exchange, the less the concentration of CO2 will be in the exhaled air. And this is why the physiologic dead space will be directly proportional to the change between CO2 concentration in the pulmonary arteries and the exhaled air. And plus, physiologic dead space is definitely the part of the tidal volume, because tidal volume is distributed among the conducting lung zone, and also the respiratory zone. So this is why we have tidal volume in the beginning of this formula. And then we can plug in the values that we'll get possibly on the step 1, and we can calculate what the physiologic dead space is from the tidal volume. For this, we should know the arterial PCO2, or partial pressure of CO2, and partial pressure of CO2 in the expired air. The physiologic dead space will change in the cases when we have the VQ mismatch, and we'll talk about more about the VQ mismatch either in today's episode or the episode that will be published in 2 weeks from this time. But what I'm trying to say is that if perfusion decreases for some reason into the certain set of the alveoli, let's say the patient has the pulmonary embolus, which obstructs the pulmonary artery, then those alveoli will also have the dead space. So alveolar dead space will increase, and therefore physiologic dead space will also increase. To summarize, VQ mismatch due to decreased perfusion increases the physiologic dead space. And this was the discussion of the physiologic dead space. Now we will talk about the difference between the minute ventilation and the alveolar ventilation. The minute ventilation is the amount of air that goes in and out of the lungs per unit time, most commonly per minute. In other words, this is the amount of air that we inhale and logically exhale in 1 minute. And after this explanation, the formula for the minute ventilation will make a perfect sense. First of all, minute ventilation is designated as V subscript E, and it equals to tidal volume times the respiratory rate. And let's break down this formula once again. So tidal volume is the amount of air that we inhale on one quiet inhalation, and the respiratory rate is the frequency or the amount of how many times we inhale per minute. So if we multiply these two values by each other, we'll receive the minute ventilation. Now, what is the alveolar ventilation? In case of alveolar ventilation, this is the amount of air that participates in gas exchange per unit time. Please, let's draw our attention to one extremely high yield fact. Alveolar ventilation is not the amount of air that reaches alveoli per minute. It's the amount of air that participates in gas exchange per unit time. And this distinction is very important because several minutes ago we talked about the difference between the physiologic dead space, anatomic, and the alveolar dead space. And we said that some alveoli, especially in the lung apices, have the alveolar dead space. In other words, they do not participate in gas exchange. And the alveolar ventilation formula does not exclude such alveoli. So this formula is like this. Alveolar ventilation, which is V subscript A, equals to tidal volume minus physiologic dead space times the respiratory rate. And the tidal volume minus physiologic dead space is exactly that amount of air that participates in gas exchange. The normal values for respiratory rate is anywhere from 12 to 20 breaths per minute. However, usually the normal values are given somewhere from the 14 to 16 breaths per minute. Tidal volume, as we already mentioned, is approximately 500 milliliters per breath. And physiologic dead space that we have not mentioned about, the amount, is approximately 150 milliliters per breath. 150. This was a conversation about the distinction of minute and alveolar ventilation. Moving on, now let's talk about the elasticity, compliance, and the hysteresis. Elasticity, or elastic recoil, is the tendency of the lungs to collapse inward. In other words, we know that during the inhalation, alveoli get stretched by the inhaled air. And the elasticity is how much the alveoli get back to their normal size after the exhalation. And the elasticity is created by the interstitial fibers and the connective tissue proteins, and at the same time surface tension on the inside lining of the alveoli create the elasticity or elastic recoil. In other words, they want the alveoli to be collapsed. However, not only the lungs have elastic recoil, but the chest wall itself also has the elastic recoil. And in contrast to the lung elasticity, the elasticity of the chest wall is the tendency of the chest wall to be pushed outwards or to spring outwards. And do you remember when I told you that the FRC was a very important point in the lung respiration mechanics? This is when we will explain why this is the case. Functional residual capacity, in other words, the air that we have in our lungs after a quiet expiration, is the point at which the elastic recoil of the lungs and chest fully balance each other. Meaning, the elasticity of the lung equals to the elasticity of the chest wall. Therefore, we don't get the collapse of the alveoli because the elasticity of the chest wall prevents the alveoli from collapsing. And what's the mechanism behind this? We said that the elasticity of the chest wall means that the chest wall wants to spring outwards, right? So it wants to expand outwards. And when the chest wall expands, it creates what kind of pressure in the pleural cavity? Is it positive or negative? Well, I hope you're telling me that it's negative, right? Yes, it creates a negative pressure in the intrapleural cavity, and the negative pressure in the pleural cavity prevents the alveoli from collapsing. Therefore, the question might ask you, at which point in the lung respiration process is the lung and chest wall elasticity equal to each other? And this will be the FRC. Additionally, the pulmonary vascular resistance is minimal at the FRC. In other words, whenever we inhale or whenever we exhale, the pulmonary vascular resistance increases, or the pulmonary vessels get vasoconstricted. And let's explain this phenomenon. When we inhale, the alveoli expand. Is that right? And when alveoli expand, they compress the pulmonary capillaries in the interstitial lung tissue. In other words, they constrict the pulmonary capillaries, and this explains why pulmonary vascular resistance will increase during the inhalation. Now, what happens during the exhalation? In case of exhalation, the intrapleural pressure increases, which forces the air out of the alveoli into the atmosphere. And at the same time, this increase in the intrapleural pressure compresses those interstitial pulmonary capillaries and increases their resistance. Therefore, it's only at the FRC when the pulmonary capillaries maintain their minimal resistance. And I would like to recommend you that you just look at those graphs which depict the inhalation, alveolar pressure, and the intrapleural pressure changes during the respiration process. But let's discuss them orally in our today's episode. The first question is super simple. What happens to the lung volume when we inhale? Of course, it increases, right? And when we exhale the air, the lung volume decreases. Okay, now the question becomes a little bit harder. What happens to the alveolar pressure during the inhalation? Does it increase or does it decrease? I hope you're telling me that it decreases, and let's explain why this happens. In order to direct the flow of any substance, for example, the blood, for example, air, we need the pressure difference between two places. And the substance, either blood, fluid, or the air, always flows from the high pressure to the low pressure. In other words, the area with the high pressure forces that substance towards the area with the low pressure, which can accommodate this substance. Let's take this phenomenon and talk about the lungs. When we want to inhale, the air must go down from the external environment into the alveoli, which means that the alveolar pressure must decrease below the point of atmospheric pressure to create the pressure difference, which will direct the airflow from the external environment into the alveoli. This is why alveolar pressure decreases during the inhalation. And the opposite will be true during the exhalation. When we exhale, we direct our air from the alveoli to the atmosphere. Therefore, the alveolar pressure must increase above the point of the atmospheric pressure in order to create the pressure gradient, which will push the air from the alveoli, or the high pressure area, to the atmosphere, which during the exhalation is a lower pressure area. And finally, let's also talk about the changes in the intrapleural pressure during the respiration process. What do you think will happen to the pleural pressure when we inhale air? Will it increase or will it decrease? I hope you're telling me that it will decrease Otherwise, I'll kill you. Yeah, so like intrapleural pressure decreases during the inhalation because when we inhale, the chest wall expands. Therefore, there is more space in the intrapleural cavity, and this pressure is distributed on the larger space of the pleural cavity. That's why the intrapleural pressure will decrease, which will allow the alveoli to expand properly. And the opposite will be true for the exhalation. When we exhale, the chest wall comes down or tries to collapse. And when chest wall comes down from the inhaled position, it increases the pleural pressure, which forces the air out of the alveoli into the atmosphere. Therefore, during the exhalation, the intrapleural pressure should increase. Okay, now that we've talked about the elasticity of the lungs and the chest wall, let's now discuss the compliance. Compliance is an exact opposite of elasticity. They are antonyms for each other. And what I mean by this is that whenever elasticity of the lungs or the chest wall increases, the compliance of the respective system will decrease, and vice versa. So they change in the opposite directions. And compliance is the distensibility of the lungs. In other words, how easy it is to distend the alveoli with the air. If we want to be more specific, talking about the formula, the compliance is the change in the lung volume per unit change in the transpulmonary pressure. And the formula is delta V, V is the volume, divided by delta P. P signifies the pressure. And it's inversely proportional to the lung stiffness. And this is what we are going to talk about right now. We're just going to briefly review it, and then we will apply our studied concept to the respiratory pathology series. When do we have an increased compliance? Can you remember these scenarios when it's easy for the lungs to fill with the air? I hope that you're telling me that it's, for example, normal aging, which causes degradation of the interstitial elastic fibers in the lungs. At the same time, emphysema, which is just part of the COPD, is also the cause of increased compliance. In these patients, it's easy to fill the lungs with air. However, it's hard to exhale the air. More on this in the respiratory pathology series. Okay, now could you please remind me the conditions in which the compliance decreases? Yes. This is when we have, let's say, interstitial pulmonary fibrosis, which forces the alveoli to collapse. Pneumonia also decreases the compliance because of the interstitial infiltrates. ARDS decreases compliance because it decreases the surfactant concentration. And if you remember, surfactant decreases surface tension. Well, if we don't have surfactant, then surface tension or the surface tension and collapsing pressure increases, which is the same as elasticity, and the compliance will decrease. Compliance will also decrease in pulmonary edema because during the pulmonary edema we have the transudates not only in the alveolar lumina but also in the interstitium. Okay, and finally, let's wrap up this topic specifically by talking about the hysteresis. What is hysteresis? Hysteresis is the difference between the lung inflation curve and the lung deflation curve. And the only thing that we should know about the hysteresis is its mechanism or cause. The reason we have the different curves for the lung inflation and deflation is that when we inhale the air, surface tension, or we can say collapsing pressure, which is surface tension divided by the radius, right? 2 times surface tension divided by the radius. So surface tension and the collapsing pressure, they work against the inhalation. They resist the inhalation, and this is why it is hard for the lungs to expand in that sense. However, when we exhale, the surface tension, collapsing pressure, and the elasticity, which are almost the same concepts in terms of the respiration process, work in favor of the exhalation. So they want to collapse the alveoli, and when we exhale, we force the air out of the alveoli, right? And you can imagine that exhalation is in accordance with the surface tension. Therefore, it's easier for the lungs to exhale the air from the alveoli. And this difference gives us the hysteresis. Okay, this was discussion about elasticity, compliance, and hysteresis. Now we will briefly discuss the hemoglobin. Hemoglobin is the molecule, not the molecule, but the protein circulating in the blood, which carries the oxygen to the tissues. The hemoglobin unit, just one hemoglobin, consists of 4 peptides. So it's a tertiary protein structure, right? And it is composed of 4 polypeptide subunits, as we mentioned. And if we talk about the adult hemoglobin, it is composed of 2 alpha chains and 2 gamma chains. Each chain has its heme group, and as we know, in the middle of the heme group, there is an iron, which is, in its reduced form, it is the ferrous iron. And the ferrous iron is the type of iron that binds to the oxygen. So each hemoglobin can carry 4 oxygen molecules to the tissues. A very important point on the hemoglobin is that this is an allosteric molecule, and it exhibits a phenomenon called positive cooperativity, which means that binding of oxygen to one subunit of the hemoglobin increases the oxygen affinity for the other subunits incrementally. And therefore, it's easier for every other oxygen molecule to bind to the hemoglobin, which is partially saturated at this point. Oxyhemoglobin, or hemoglobin saturated with oxygen, has the relaxed conformation, and these 4 subunits can move relative to each other. But deoxyhemoglobin has T or taut conformation, which means that the 4 subunits are very tightly situated relative to each other, and therefore they don't move relative to each other. This point will become very important when we discuss the sickle cell disease and the process of sickling in the hematology section. But now let's get back to the oxy and deoxyhemoglobin. Deoxyhemoglobin itself has low affinity for the oxygen. In other words, once the hemoglobin starts unloading the oxygen, then it becomes easier and easier and easier to unload every other molecule of oxygen. And finally, the hemoglobin, the globin part of the hemoglobin, or the proteins, specifically the histidine residues, are the buffer for the proton ions, meaning hemoglobin can bind to the hydrogen ions, and this is the predominant form of how the carbon dioxide is brought from the peripheral tissues to the lungs for the exhalation. So carbon dioxide is broken down into bicarbonate and the proton, and so the proton is carried attached to the hemoglobin while bicarbonate is carried in the plasma. Let's compare hemoglobin to myoglobin briefly. Myoglobin has the similar structure in a sense that it has the peptide or globin, which itself is a tertiary protein structure or tertiary peptide structure, and it has the heme group with the ferrous iron in the center. Myoglobin is called myoglobin because it's present in the muscles and it preserves the oxygen for the muscle metabolism and the electron transport chain for the ATP production. Why is not a myoglobin an efficient oxygen transporter? In other words, why don't we also have the myoglobin in our plasma? We don't have the myoglobin in plasma for the oxygen transport because myoglobin has a very, very high affinity towards oxygen, much higher than that of hemoglobin, which means that if myoglobin were in the plasma, it would not unload oxygen towards the peripheral tissues while going through the peripheral tissues. This is in contrast to hemoglobin, which definitely unloads the oxygen, especially when the CO2 binds to the hemoglobin, mostly in the form of the hydrogen ions and also in the form of the CO2. So this was the brief overview of the hemoglobin and the difference of hemoglobin and myoglobin. We will finish our today's episode by talking about methemoglobinemia, carbon monoxide, and the cyanide poisoning. Let's start with methemoglobinemia. We already mentioned that normally the iron in the heme group of the hemoglobin is the ferrous iron, meaning it's in the reduced form and it has the valency of +2. However, there are many oxidants constantly produced in our body, and these oxidants might intermittently oxidize the iron +2 into iron +3, which is called the ferric iron. The problem with this is that the ferric iron cannot bind to the oxygen. It can bind to the cyanide, which will be very important in the management of the cyanide poisoning. We'll talk about it later. However, it cannot bind to the oxygen. Therefore, when we have methemoglobinemia, the oxygen saturation will decrease. And at the same time, what happens is that there is a leftward shift in the oxygen hemoglobin dissociation curve. We will talk about this curve in the next physiology session. However, the idea is that if we have, let's say, 2 oxidized iron in one hemoglobin molecule and 2 reduced or the normal iron in the hemoglobin molecule, even if the reduced form of the irons bind to the oxygen, they will not be able to unload that oxygen to the tissues. Methemoglobinemia will have the cyanosis because the oxygen saturation is decreased, and the cyanosis will not improve with the supplemental oxygen. Do you have any thoughts why? I hope you're telling me that since in methemoglobinemia we have the iron in the oxidized form, or ferric iron, iron +3, it cannot still bind to the oxygen no matter how much oxygen we give to the patient. So what we need is to administer the antioxidants, the substances which will reduce the iron to its iron +2 form or the ferrous form. And the first line treatment for the methemoglobinemia is the methylene blue, which will donate its electron to the iron so that iron +3 becomes iron +2. And the additional treatment that we might need to do is the vitamin C or the ascorbic acid. Because let me remind you that ascorbic acid is one of those 3 vitamins which are antioxidants. So it's vitamin A, C, and E. And now we're talking about the vitamin C. If the patient has methemoglobinemia, they have this chocolate-colored blood, which is kind of buzzword for the methemoglobinemia, and it has the distinct mechanism. Have you ever seen some, some equipment, iron equipment, which is oxidized because it's old? What color is the oxidized iron equipment? It's brownish, right? So the same thing. In this case, the iron gets oxidized inside the hemoglobin molecule, and the oxidized iron gives the blood this brownish chocolate color. The only thing that we need to add onto our discussion about the methemoglobin is what can cause methemoglobinemia. Any oxidant stress can do it. However, mostly this is caused by the medications, and from the medications, sulfa drugs and the nitro drugs are notorious for causing methemoglobinemia. For example, dapsone, even though dapsone is not the sulfa drug, it can still cause the methemoglobinemia. Local anesthetics can definitely cause the methemoglobinemia, for example, the benzocaine and nitrates, right? And nitrates can be ingested from, let's say, the food or from the high altitude water, or if the water is poisoned simply by the nitrates. And we also have this enzyme, all of us, which is called methemoglobin reductase. This is cytochrome enzyme, as I remember. And the methemoglobin reductase normally reduces this iron plus 3 to iron plus 2. However, in infants, the methemoglobin reductase is immature, so it cannot efficiently convert oxidized iron to the reduced iron. So infants are at higher risk for the methemoglobinemia. Now let's move on to carbon monoxide and the cyanide poisoning. They have the similar mechanism of action. Both of them, carbon monoxide, cyanide, and by the way, the azide, if we recall our biochemistry, inhibit the complex 4 of the electron transport chain. Do you remember which enzyme is the complex 4? This is the cytochrome C oxidase. This is the enzyme which takes the electron from the cytochrome C and then gives this electron to the oxygen to make the reactive oxygen species. And this is the last complex before the complex 5, which is the actual ATP synthase. And if both cyanide and the CO block the complex 4, they inhibit the electron transport chain. So they inhibit the aerobic metabolism, and the body moves to the anaerobic metabolism, or the glycolysis. And do you remember what the byproduct is for the anaerobic metabolism? I will kill you if you don't remember this. This is the lactic acid. And so patients with cyanide and carbon monoxide poisoning will have lactic acidosis. This is the common feature. However, we should now compare and contrast these two poisonings. First of all, what can cause the cyanide poisoning? Well, any synthetic product combustion, the fires can cause the cyanide poisoning. At the same time, there's this very weird and the peculiar substance called amygdalin, which is present in the apricot seeds, and the amygdalin is the cyanogenic polysaccharide. So amygdalin can cause the release of cyanide in the body if the person accidentally ingests the apricot seeds. There might be an accidental or intentional cyanide poisoning in a suicide or the homicide attempts. And as we already mentioned, the fire victims and the burn patients might have cyanide poisoning. Carbon monoxide is produced by the partial combustion of the oxygen. Therefore, the car exhaust and the gas heaters and the fire victims are at very high risk for the CO poisoning. In both cases, we will have the altered mental status, so we might have the drowsiness, we might even have the seizure and coma if we have severe cyanide or the CO poisoning. Headache is usually the first sign of the CO and the cyanide poisoning as well. The cherry red skin is a non-specific finding which can be present in both cyanide and carbon monoxide poisoning. So please don't associate this cherry red skin only to the carbon monoxide. And what is different about the cyanide is that the breath in the cyanide poisoned patient will have this bitter almond odor. So if you hear that the patient's breath smells like the bitter almond, that's it. That's the cyanide poisoning. In case of carbon monoxide poisoning, the skin might also have the bullae, which are these large blisters more than 1 centimeter in size, and carbon monoxide might be a collective poisoning, meaning if there is a dysfunctional gas heater in the family, then multiple family members might be simultaneously poisoned with the carbon monoxide. What happens with the laboratory findings in either of these poisonings? Well, in cyanide poisoning, the PaO2 will be normal because the oxygen diffusion from the alveoli into the pulmonary capillary is absolutely normal in the cyanide. However, as we already mentioned, there is elevated lactate and there is metabolic acidosis. And in cyanide and the carbon monoxide poisoning, we have functional hypoxia, meaning the tissue oxygen concentration is actually normal. However, the idea is that the oxygen cannot be used because the complex 4 is inhibited. In case of carbon monoxide, PaO2 will also be normal because, once again, oxygen diffusion from the alveoli to the pulmonary capillaries is intact. However, carboxyhemoglobin levels will be elevated. Carboxyhemoglobin is the hemoglobin molecule bound to the carbon monoxide. And I'm going to tell you a very high-level thing. Regular pulse oximetry cannot differentiate carboxyhemoglobin and the oxyhemoglobin. Therefore, you might erroneously get the normal pulse oximetry findings in the CO poisoning. So for this, we need the co-oximeter, which will tell us that this is the carbon monoxide poisoning. And very high yield thing, carbon monoxide poisoning can cause the bilateral increased intensity in the globus pallidus on the MRI. It might also be seen in the cyanide poisoning, but it's more classic for the carbon monoxide poisoning. Now let's briefly mention what happens to the oxygen dissociation curve with the CO and the cyanide poisoning. In case of cyanide poisoning, the curve is absolutely normal because cyanide itself does not bind to the hemoglobin molecule. In case of the carbon monoxide, there's a left shift because when carbon monoxide binds to the iron, then it increases the affinity of the hemoglobin towards the oxygen, so the carboxyhemoglobin cannot unload the oxygen towards the tissues. And at the same time, oxygen carrying capacity will decrease because carbon monoxide has more than 200 times greater affinity than the oxygen for the hemoglobin, so there are less binding sites for the hemoglobin. Now, how do we treat them? For cyanide, we should first decontaminate the patient, for example, remove the clothing because cyanide can also be absorbed through the skin. Then the first thing that we give is hydroxycobalamin, which is the B12 variant, and it can produce the cyanocobalamin, which is then renally excreted. We can also give the nitrites because nitrites will cause methemoglobinemia, and as we mentioned earlier, methemoglobin can bind to the cyanide. So we can get cyanomethemoglobin, which will take away the cyanide from the tissues and decrease toxicity. And finally, sodium thiosulfate can work in cyanide poisoning because sodium thiosulfate provides the sulfhydryl group, which converts the cyanide to sodium thiocyanate. And this happens by the mitochondrial enzyme called rhodinase. And the sodium thiocyanate is renally excretable substance. As for the carbon monoxide poisoning, the first line treatment is the 100% oxygen to displace the carbon monoxide from the hemoglobin. And if the 100% oxygen doesn't help, then we go to the hyperbaric oxygen to further displace the CO from the iron of the hemoglobin molecules. Okay, so we have talked about many different topics today, and let's summarize everything that we have discussed in our episode. Today we discussed the lung volumes and the capacities, and we should know their definition, their formulas, and their interrelationship. We have also talked extensively about what the difference is between physiologic dead space, alveolar, and the anatomic dead space. We have also differentiated minute ventilation from alveolar ventilation. We have discussed the compliance, elasticity, and the hysteresis. We also briefly reviewed the hemoglobin, and finally, we wrapped up our discussion by discussing the methemoglobinemia and differentiating cyanide and carbon monoxide poisoning from each other. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, USMLEers, and see you on the next episode.